Good morning, good afternoon, colleagues. We are starting in 1 minute exactly. Hi, Brian. I can hear you and I can see you. I can confirm we can hear you and see you, Brian. Thank you.
Okay.
Good morning, good afternoon, good evening to everyone. I can see there's quite a number of people who have joined or who are still joining, but I am ecstatic, to welcome you to this side event of the UN General Assembly on the role of faith communities in supporting adolescent prevention, treatment, and care in the HIV response. My name is Wale Ameyan, and I work with the World Health Organization here in Geneva as technical officer on adolescent HIV. Whilst giant strides have been made over the years in the HIV response, there is still quite a way to go. Some would say quite a long way to go. However, there is certainly an understanding now that we need to focus more on what truly matters to people and the communities in which they live. It is why I am very delighted to facilitate this, this session organized by the UNAIDS PEPFAR Faith Initiative with faith partners and leaders around the world. Just a few things before we start and we set the ball rolling. First of all, it is to let you know that interpretation of this session is available in English, but also in French. So if you would like to, click on your language preferences, that would be super. We would like to make this session as participatory as possible. We would like you to, get in the chat box, offer your suggestions and recommendations. Let's make this a lively event. Now, as you do that, we would like you to have one question, probably a couple of questions in mind. The first is, how do we reach the targets that have been set for adolescents in the AIDS global strategy and the political declaration? But also a second one, which is closely linked to that, which is how can we better work with the faith communities and how can we promote adolescent leadership and involvement in the HIV response? We would like to hear your suggestions and recommendations, so please use the chat box for your comments as well if you have questions. Just a keynote to say that this session is being recorded and your participation is deemed consent for the recording, so thank you very much. Also to say, that all of the resources, all of the presentations that you hear here will be posted on the Interfaith Health platform, which you can see on this slide, the website, where you can see all of the videos, the resources, the advocacy materials, as well as all of the information about this session on that website. Importantly, I would like to just mention the 12 million campaign. This is a campaign with really lofty objectives and ideals to mobilize action to ensure that 12 million children, women, and men who are currently living with HIV, but who do not have access to the optimal life-saving antiretrovirals, what we call the ART. This campaign is about getting those 12 million access to these treatments, and for them to remain on treatment and to be virally suppressed. On the next slide, I will just go through the objectives of this session. It's going to be an interesting, exciting session that has 5 objectives, and I'll just go through those quickly. First of all, we want to provide faith leaders and representatives of faith-based organizations and communities with a clear sense of what is needed. What are the action areas that are needed and that are related to adolescents and HIV from the political declaration, but also from the global AIDS strategy. Secondly, we want to hear from you. We want to hear from adolescents, the young people, about their lived experiences, but also we want to know what the challenges are and what recommendations do you have for the faith sector moving forward. Importantly as well, we would like to identify key interventions through which our faith leaders, the communities, can help to support this response in reaching the targets for prevention, for testing, for treatment, and for virus suppression for adolescents. Next, we would want to engage, of course, faith-based organizations and leaders in the 12 million campaign, such a lofty campaign that I just mentioned earlier on committing to those key actions to promote greater access and equal access as well to adolescents living with HIV who are not yet on treatment. And then finally, we will have promising practices, good practices, exciting ones by faith communities for better health outcomes amongst adolescents and young people themselves. So we have a packed agenda. It's an exciting one as well. We will start off with welcome and opening remarks from 2 people who really need no introduction. So I'm not going to be going into any in-depth introduction. You would find their bios on our website. So first we'll have, and such a pleasure as well, Dr. Shannon Haider, who is the Deputy Executive Director of Programs in UNAIDS. We will then have immediately after Dr. Anjali Atreka, who is the acting US Global AIDS Coordinator and Special Representative for Global Health Diplomacy at PEPFAR. Following that, we will have the fantastic Dr. Chewe Luo, who is Director of HIV at UNICEF, who would set the scene, put us in context on adolescents and HIV in the context of COVID. We will then end that first session with words of prayer. Following that, we will go into back-to-back sessions. Session 1 would be about the challenges in front of us, particularly as it relates to adolescent leadership and how we can put adolescents and youth at the center of the response. For this, would have a nice blend of recorded videos, but also live from Franklin Wanyama from EDAP, Kenya. Would have Brian Kipchumba from Kenya as well. And then finally, we have Vanessa Fernandez from Human Touch India. I am really looking forward to hearing from all of them. I'm sure you all are. The second session, goes very nicely from there. Having looked at the challenges, we want to look at solutions. What are the lessons that we can learn from these good practices? And on that, we have an exciting cast from Gladys Mukara Tirwa, who's a program coordinator at Chiedza Community-Based Orphan Welfare. Would have Anthony Mtali Ngwira, who is a country programs coordinator with the New Apostolic Church Relief Organization, NACRO. And then we would also have Tiffany and Colin Moody from the from the Luke Commission on the teen clubs. Really, really excited. After that, we'll have time for discussion. So please, have that question I had in mind so that you can put in your questions and your comments into the chat box. We will finish off with closing and way forward from Sandy Thurman, who is Chief Strategy Officer of the Office of the U.S. Global AIDS Coordinator and Health Diplomacy, and also Suki Beavers, who is Director, Gender Equality and Human Rights Community Engagement with UNAIDS. So as you can see, we have a really fantastic agenda, and I'll just get straight into it by inviting, first of all, Dr. Shannon Hader, who would then be followed by immediately by Dr. Anjali Atreka for their opening remarks. So let me hand it over to Dr. Shannon now.
Great, thank you so much. I just want to say welcome to everyone, and especially the young people who are joining this important event of the UNAIDS PEPFAR Faith Initiative. As many of you know, the organization of an UNGA high-level side event about the impact of faith on the HIV response has become an annual tradition. And while we can't yet meet in our usual interfaith prayer breakfast, we are very glad to have you all with us virtually. And I think we've learned through this year, including for one of the 12 million response planning sessions, that in fact, we've sometimes gotten larger volumes and more diversity in our virtual or hybrid events like this. So I am very excited about it. So first, let me express my highest appreciation of our partners from PEPFAR, who since 2015 have supported programmatically and financially our joint faith initiative. We're pleased to see its positive impact on the HIV response, including through the increase of faith leaders from different religions and geographic regions who have become champions of the response. I'd also like to recognize the role of these faith leaders in the recent development of the new global AIDS strategy, as well as your presence at today's events. And finally, sincere thanks to Anjali for your thoughtful and inclusive leadership and your clear dedication to the HIV response during the last difficult months. So why are we here today? Youth are important to our communities, to our future, and to the HIV response. And as much as we say that, we don't always follow it up with action. You know, youth 10 to 19 years old today have specific needs when it comes to HIV. Whether it's navigating living with HIV while growing up, coming of age, entering adulthood, whether it's being empowered to prevent HIV infection, not just for the next few years of their lives, but for a lifetime, they have specific needs that need to be addressed now. And as we move into the next era of the HIV response with a new global AIDS strategy, with more tools than ever, but with so much work left undone, it's time to raise our expectations and do better at creating space for young people to be fully part of co-leading and co-designing the HIV response that will work for them. We need to listen to, share, and exchange ideas with our young people. What should we do collectively better to support access to HIV prevention, treatment, and care services? And most importantly, how should we better promote youth leadership in the HIV response? What are the unique and compelling aspects of the faith response and faith communities that are most important and most vital to young people in their response to HIV? And how has the last 18 months of surviving the COVID pandemic, something that's still not over, changed these needs or taught us something new? And we need to acknowledge that young people are not a homogeneous group. We need to address the needs of young people in all their diversity, especially those who are most often marginalized and left behind. That includes reaching out to adolescent girls and young women and young men from key populations with tailored approaches that meet their specific needs. We must build bridges for those who are most often excluded, such as adolescents who are gay and transgender, adolescents who use drugs, migrants, homeless, and those in closed settings. We need to understand what needs are the same for young people living with HIV who were infected vertically a long time ago, as well as for young people who were infected more recently as adolescents. And we need to understand what needs are distinctive or different for them. We need to understand specific issues around stigma, disclosure, family, and community supports. And so we hope to break down barriers for youth participation and leadership at all levels of the response, especially where political and programmatic decisions for the HIV response are being made. We need increased investment in youth-led responses and young people's leadership. That's an important step to achieve the targets that you mentioned that are related to young people. And so I am pleased that the faith sector is keen to strengthen its engagement with young people and will band together to support reaching the targets set in the Global AIDS Strategy and in the political declaration, which we've named Ending Inequalities and Getting on Track to End AIDS by 2030. You know, in the political declaration, UN member states have committed to achieving 95, 95, 95 in testing, treatment, and virus suppression for each affected group, and that includes the group of adolescents by 2025. They committed to greater involvement of people living with HIV as a principle, and to empower communities of people living with and at risk of and affected by HIV, including adolescents and young people, to play their critical leadership roles in the HIV response. So engaging adolescents in all aspects of HIV programming should be a no-brainer. It increases use of services, it ensures that the services are actually meeting critical needs, not in just what is being delivered, but also how and where and who is delivering them. So to end AIDS among children and youth, we know that we need to leverage the contribution of each sector, including and especially the faith sector. Faith communities have been champions for children over the years. They make distinctive contributions to adolescents' HIV response. And still, in faith settings, as in most other settings and sectors, more can be done to promote adolescents' autonomy and capacity to lead and co-lead the response. So today, I look so much forward to hearing about promising practices by faith-based organizations and faith communities for better health outcomes among young people, and especially hearing about interventions led by young people themselves. I look forward to hearing from young people about your lived experiences, your challenges, and your recommendations that matter and will help us in shaping a future without AIDS. So thank you for all being here, and I will hand it over. Thanks.
Great, thanks so much, Shannon. And let me echo just a warm welcome to everyone. It's really fantastic to be together today. And a very special thank you to Francesca Marico and the entire UNAIDS team. We know how hard and difficult pulling this event off every year is, and we're just so grateful. This is really an important moment when we all come together with faith-based organizations and leaders from all faiths and all sectors to really review our progress, strengthen our partnerships, and recommit to addressing gaps and inequities in our HIV response. So I really just want to start off by saying thank you to the team that continues to work hard to organize us on the UNAIDS and PEPFAR Faith Initiative. But again, really excited to dive in today. Today's conversation, as Shannon noted, is focused on adolescents, strengthening our efforts to promote HIV prevention, treatment, and care among them, and importantly, and essentially to ensure that they have a role in leading in the HIV response. Faith-based organizations and faith leaders have been essential partners in the response to HIV since the very beginning. They are critical, they remain critical, and it's really important that we continue to engage to respond with the faith community, to respond to the unique challenges and needs of children and adolescents. And as Shannon also noted, this is not a homogeneous group. we really need to target and tailor our interventions to best meet their needs. And there really is currently no greater need in our efforts to control the HIV and AIDS epidemic than empowering adolescent girls and young women, engaging adolescents as key partners, and also focusing on men and boys as part of the solution. We know that each week, around 4,600 adolescent girls and young women are infected with HIV. Girls account for over 3/4 of new infections among adolescents in Eastern and Southern Africa. Continuing to decrease new infections in this population is absolutely critical, particularly with the demographic youth bulge in Africa that we know and we've talked about previously. So we must be bold and act with urgency. We must move forward with comprehensive programming that addresses social, economic, and biomedical interventions to both reduce girls' vulnerability to HIV and increase their agency. This is what we've been trying to do and pushing through our DREAMS partnership with many of you. We must work with and for adolescents through the prisms of gender and rights and ensure enabling environments to help promote and support them. And we must step up our efforts to strengthen HIV testing and treatment programs specifically for adolescent needs that also reach their male sexual partners as well. As Shannon mentioned, engaging adolescents in all aspects of HIV programming not only improves young people's utilization of services, but it also helps to ensure that these services respond to young people's needs and their preferences. This has been a cornerstone of the success of the DREAMS program, and we know is critical as we move forward together. But what are some of the key solutions that we might all embrace, leveraging the unique reach, relationships, compassion, and structures of communities of faith? They might include promoting community outreach through existing faith community groups, perhaps creating demand for HIV services using places of worship and regional school and religious schools rather. Maybe also advocating to address stigma and discrimination and sexual and gender-based violence. These are among the few that we may consider. Yet in faith settings, so much more can be done to promote adolescents' autonomy and their capacity to lead the response. And today, we're really, really excited to hear from adolescents and faith leaders alike to find better ways to reach young people with life-saving prevention and treatment services that they deserve. We look forward to being part of this discussion and working with you as we move forward, continuing to advance the UNAIDS PEPFAR Faith Initiative and impact the lives of so many around the globe. Thanks so much. Look forward to the discussion.
Absolutely spot on. Thank you so much to Anjali and Shannon. I couldn't agree more in terms of raising our expectations, but also being responsive to the comprehensive needs of adolescents and young people across the cascade, but also in their diversity. Thank you so much for those welcome remarks. I would now move forward on the agenda as this is a faith event. We would have a word of prayer. And can I just invite Michelle from Kenya, who would give us her opening prayers. Over to you, Michelle.
Hi, my name is Michelle Wanjiru. I'm from Kenya. This is a prayer for adolescents living with or personally affected by HIV and AIDS. Let us pray. God, we thank you because you're an everlasting God and creator of the ends of the earth. You do not grow tired or weary, and your understanding no one can fathom. You give strength to the weary and increase power to the weak. God, heal us adolescents from bodily pains from HIV and AIDS that deplete our immunity and leave us open to opportunistic infections. Heal us from broken hearts and grief that continues to pain our spirits and minds and leave us empty about the meaning of life. Heal us from psychological pains of HIV that put us in fear and hopelessness and lead us to die before the virus kills us. Some of us have lost our parents, God. You have promised to be a father to the fatherless, Please provide grace and hope to carry on with life. My soul pleads for mercy. My heart is saddened by the stigma and discrimination around us, against us, and in us. Who will listen as we scream? Who will see our tears? No one but you, O God, our source of strength. You have chosen us. You have seen our weakness and strength. Let your voice bring hope to the highest mountaintop. May love teach us to bring life and hope to those who have lost it. In Jesus' name we pray. Amen.
And a big amen. Thank you so much, Michelle. So we'll now move forward, and I'll have the pleasure of inviting Dr. Chewe Luo. Dr. Chewe Luo is Director of HIV with UNICEF, and Chewe will help us with setting the scene. Where are we and where do we need to be going on adolescents and HIV in the context of COVID. A pleasure to have you, Chewe.
Thank you, Wale. I'm really excited to be part of this important discussion on adolescents.
Can you hear us, Chewe? Because we can't hear you.
I'm not muted. You can't hear me?
Probably her microphone is somewhere. It's very low.
Yeah. We still can't hear you, Chewe.
Chewe, it looks like your microphone is far from you.
No, I am very close. I'm actually using a laptop. I'm so sorry. I don't know why this is happening, but maybe you can help me and tell me. Hello.
So Chewe, I'm sure you're speaking already, but we can't hear you. The microphone is not projecting your voice.
Can they help me? Hello? Hello?
Yes, it's better now, Chewe.
You can hear me?
Yes, please, go ahead.
Right, okay, no, thank you. And I'm really excited to be part of this panel and to give this presentation on the overview of HIV and adolescents, a population that all of us need collective action on. And when I finish my presentation, you'll see why I'm saying that. Next slide. So as an outline, I'll give an overview, really setting the scene of where we are in terms of numbers. I'll talk a little bit about the epidemiology of HIV in adolescents, but also where we are with the response, and I'll end with some takeaway messages and probably a call to action. Next slide. So in terms of numbers, we know that today we have over 37 million people living with HIV, and 1.75 million of them are adolescents between the age of 10 to 19. Just a statistic there to note that out of the 1.75, 1 million are girls. But when it comes to new infections, every day, and this is data from 2020, every year we have about 160,000 new infections amongst adolescents. But I want you to note that the majority of those infections, 120,000, are actually in adolescent girls. So you take note of that, the difference between the number living with HIV that are girls and the number of new infections that are girls. So already you can see that 76% of new infections amongst the adolescent age group is actually in girls. And then when you look at mortality, we have about 32,000 adolescents dying every year, and we had parity between girls and boys. Next slide. So moving on, when we look at the 1.75 million adolescents living with HIV, 9 out of 10 live in sub-Saharan Africa. And this pie chart just demonstrates where these children reside. And you can see that Eastern Southern Africa takes up 70% in the blue, and then Western Central Africa takes up 13% in the orange. In totality, that makes up about 90% of new infections. But we should not ignore the fact that we still have adolescents living with HIV in the other regions. And these are populations that are totally marginalized and uncounted in some of these regions. So we have to look at inequities everywhere. Next slide. When we look at the new infections, and I said we have about 160,000 of them, and this slide is reflective of what's happening in terms of gender or the sex distribution of the new infections. And it's actually alarming when I look at the slide that region by region, we talked about the 77% of new infections being in girls, but you can look across the bars that region by region, there's that disproportionate affection of girls. But I want to draw attention to East Asia and the Pacific, where 36% are in girls, and we have more boys there being affected. But South Asia is 51%, Latin America is 51%. But all the other regions, there's a lot more girls being affected than boys. And I think that's important for us to note as we think about how to target our interventions. Next slide. It's exciting to note that new infections are dropping, and our estimate is it's a 34% reduction since 2010, and you can see the different regions there. I think much of what's drawing down the infections is the work that we're doing in Eastern and Southern Africa, and kudos to everybody that's working on this, including adolescents themselves, but also the money that's going, especially in the space of adolescent girls and young women, by the Global Fund and PEPFAR and other partners. Next slide. It's important for us to note that although new infections are dropping and we're seeing that drawdown, especially in East and Southern Africa, we also have children that are growing within our time. These are children that are vertically infected from mother to child transmission that are now transitioning out into the adolescent age group. So when we look at adolescents living with HIV, we should not ignore the fact or forget the fact that we have two different groupings of adolescents that need our support, and that these distinct populations, the children that are infected vertically that are growing into adolescence and the ones that are newly infected, in terms of what they need, I think their needs are very distinct, and we need to recognize that transitioning children who are vertically acquired into adult care or adolescent care is very challenging, and we need our collective thinking around what we do about that, especially how we transform adult treatment programs to deal with these children. Next slide. So moving on to our response, and the next few slides, I'll just touch on where we are in terms of the response. It is very saddening, and I can say that for a fact, that adolescents, when it comes to HIV testing, are nowhere near the 95% that we're supposed to be at. If you look at the bar charts here, each second bar is looking at ever tested or tested in the last 12 months. And you can see that in East and Southern Africa, amongst girls is 38% and 24%, amongst boys 28% and 16%, amongst girls in South Asia 2.5% and 1.5% in the last 12 months. And when you look at boys, similar. But what I want to highlight here, this statistic is very sobering for me, and really tells me that we really have to have a collective action on this population to figure out how to reach them using the tools that we have. But I think what is important also to note in the high bars, both for girls and boys, is the fact that they know where to get tested. And yet, when you look at the testing rates, we're nowhere near. I don't want to oversimplify this, because I do know that we need to be more targeted in our interventions. Resources are not endless, and we need to really figure out how we reach them, who we reach, and to have the yield that we need to link these children into services. So I don't want to simplify that, because this is survey data that doesn't actually triangulate against where the burden of disease and where the need is most needed. So just keep that in mind, and maybe during our conversation, we can figure out how to organize ourselves around HIV testing in adolescents, because I think it's a very important area of work that needs our collective thinking in terms of how we allocate our resources to reach this population. Next slide. Yeah, so moving on, despite the fact that, in fact, when you look at who's testing and who knows where to test, you find that actually girls are testing more, even though the boys have more information about where to test. But when it comes to adolescent treatment and retroviral treatment, we are at parity. About 50% of adolescent boys and 50% of adolescent girls are accessing treatment against the benchmark for 2020 of 95%. So you can see the gap there between our goalposts and where we are. Next slide. And this is just the distribution across regions, and you can see that South Asia is leading the charge, 61%, but I want to just point out that despite the burden of disease being very high in Western Central Africa, second to Eastern Southern Africa, only 43% in that region are accessing treatment, and you can see 20%. Next slide. And this is just the gender sex distribution, and very little difference between boys and girls across regions. Next slide. This is, now looking at the countries, and I think this is important for this discussion for people that are concerned about places where they are working. I think I've already talked about the low coverage in Western Central Africa. This is just the country distribution of coverage, and we're nowhere near where we need to be. And I think this needs our collective attention. And I just want to say that when you look at the trend of COVID, we were nowhere near, but COVID is adding complexity to an area of work where we have a lot of challenges to reach the people that need our services. Next slide. Similarly, in Eastern Southern Africa, I mean, you can see Eswatini leading the chart, 61%, Madagascar 3%, and the distribution there of what proportion of adolescents are accessing treatment in Eastern Southern Africa. I wouldn't end this conversation without talking about the fact that this is against coverage rates of 74% in adults, 85% in pregnant women, 54% in children. So I just want to say, for both adolescents as well as children, we really need to do more and come together as a coalition to address this issue. And I'm very excited, but that the faith community wants to lead the charge on this. Next slide. I think that's my last slide, Wally. So in terms of the takeaway messages, I think the data that I've presented does call for acceleration. How do we do that to reach the 1.75 million adolescents living with HIV? And what paradigm shifts do we need in terms of service approaches? We have a lot of innovations that are like self-testing adolescents. The data we have is very encouraging as to how many adolescents are accessing and really taking charge when it comes to self-testing. Digital solutions, adolescents are very connected, and I'm sure there will be some highlights of that in the next presentations. We have to work with them. Peer-led, peer support programs, how are we financing those? Do we know which ones are working well that we can take to scale? We've been working with Lucy Kluver and colleagues at Oxford University looking at a Care Plus agenda. It's not about drugs alone. It's not just about our intervention, but care in its totality, including parenting and social protection, psychosocial support, mental health. And then we have to think about the children that are transitioning into adulthood or transitioning into adolescence, and how we transform our services to make sure that the services are tailored to their needs. The coverage in Western Central Africa for me is a must do. I didn't talk about some of the projections that UNICEF has done, that if we don't do nothing in Western Central Africa, this population of young people is going to be a critical problem for the future. going into 2030, going into 2050. So inaction today is actually going to balloon out the number of adolescents in Western Central Africa that need our care. And then we need to refocus on prevention. I realize I haven't talked a lot about prevention, but in the 8 minutes that I have, I hope I've given you the overview that we need to think about what we're going to do for this population. Thanks, Wally.
OTZ Operation 000, OTZ Operation 000, OTZ Operation 000, OTZ Operation 000. Nina matangazo ya kuleta mwongozo, tulia tukitaka na upate mafunzo, fungua macho yako na utege sikio, taani ni gomuzo, hatupendi mzozo, ngoja kuelimishe kuhusu hizi zero, kizingatia hizi utakuwa weni hero. First of all, zero disappointment, usikose uka get disappointed. Maisha haina time ya ku regret, maana tamu kama kuku ya kumarinate. Siku yako iweke kwenye diary, ikifika wewe uko tayari. Mbio mbio hakuna kusita mara mbili, kama shujaa ujipate uko kule ndani. Yeah. OTZ Operation 000, OTZ Operation 000, OTZ Operation 000, OTZ Operation 000. Zero miscracks, siongele mira, wengine tunazita switi, maana imechange maisha yetu fiti. Hii ni ukweli, wenzangu si wachochi, siposikia hii adui mulangoni anataka kukumada, lazima kaya rada
Well, fantastic, fantastic interlude. We had the very famous Operation 000 interlude, a rap song from a young person there. Before moving forward, I just wanted to thank Chewe. There's, even in the chat box, there's a lot of appreciation for how you have fantastically set the scene, but also showing us what gaps there are. Without a question, there are still, really clear gaps for adolescents and young people on testing, on treatment, but also on retaining them in care. So this is, you've set the scene brilliantly, but it's also a call to action, a call to action on what are we not doing, or what are we not doing enough of, and how can we begin to do them or do more of them? So thank you so much, Chewe. And it actually dovetails really nicely into the next session. This is session 1 now, where we're going to be looking at the challenges in front of us. Challenges, particularly as it relates to adolescent leadership, youth engagement. How can we put adolescents and youth and young people at the center of this response? Because, like I always, want to say, it's really about them. It's about adolescents. It's about the communities in which they live. In doing that, I just want to encourage everyone. This is this event is for you. So I would like you to let us know what you think. If you have questions, comments, suggestions, recommendations, please put them in the chat box as we go along. So I'm going to now introduce those who would be speaking in this session 1 on challenges as it relates to adolescent engagement. First of all, we will have Franklin Wanyama from the Eastern Dennery AIDS Relief Program, EDUP in Kenya. We will then have, after that, Brian Kipchumba from Kenya as well. Both of them will give us, really nice videos on this topic. Following that, we'll have Vanessa Fernandez from Human Touch India. Fantastic to have Vanessa on the live chat with us here. and then we will go into another, really small interlude of music. So let's get into the first session. I'm excited to begin with a video from Franklin Wanyama from EDAP.
TZ president from Kenya, Africa. Being born HIV positive is not a wish that any parent would like for his or her child. I was born HIV positive, and the journey on ARVs and acceptance was not easy on my side. I started going for my clinics in 2006 at EDAP facility together with my mom, but all along I never knew what the medication were meant for, because all along my mom used to tell me the medication I was taking were meant to treat my chest, which was a sweet lie to keep me taking my medication well. I came to my senses when I was in class 5, when I got to hear much from the support groups I used to attend at EDAP. The medication and especially the spiritual support I got from the EDAP's CHWs, doctors, social workers, and staff kept me going, even though it was not that easy because my home turned to hell since my dad was HIV negative. In the family, my mom and I were the only ones living with HIV. I felt so bad seeing my parents exchanging words and even fighting, and the only thing I could hear was mom being abused for being HIV positive together with me as her son. EDAP was of much support to me in my primary school level, since they kept encouraging me to keep on taking my medication and being strong. I could go to the facility and meet my fellow children during support groups who were taking medication like me. I joined secondary school and it became more tough on my side because it was boarding, and the greatest challenge was how to take my medication in the dormitory where we shared with the other fellow students. EDAP, through the social worker, facilitated for me when I was in Form 2 to join a nearby school, which I saw it was a nice idea since I wanted to study hard and be able to take my ARVs again. I managed to study through the challenges of stigma from family and friends, but I kept praying that one day I would complete my secondary level and be able to help my mom and our family since I was the firstborn. After my secondary school, life became hell on me since my mom decided to go back to our rural home for good and leaving me in Nairobi alone. I felt abandoned and I felt like I would stop taking my ARVs medication, but I thank EDAP for encouraging me as I kept going for my classes and trainings. Life became hell on me and I saw like the burden was too much, taking my ARVs medication on a daily basis and at home. Needed to play my roles as the firstborn and losing my best friend who used to encourage me when going for support groups at EDAP. I went into depression and I decided to end my life by taking poisons. I posted on my status and covered myself in my bed and locked the door. I thank God for the EDAP staff who saw the post, called, but I could not pick my phone. I'm told they came and alerted each other and broke the door. I can't explain what happened in between, but I found myself at Mama Lucy Hospital at 1 a.m. surrounded by Dr. Mtuko, Dr. Jasper, Teresia, and my fellow peer mentors and friends on the hospital bed. With the help of EDAP psychologists, I managed to overcome and the ongoing spiritual care which keeps me going strong. Since then, I found myself going publicly on my HIV status and standing firm to give hope to my fellow adolescents and young adults living with HIV and the community at large who are living with HIV that there is hope. I have been on media and several social media and networks to advocate for prevention, staying on care, and also end of HIV, discrimination, and stigma. I want to take this chance to thank all EDAP staffs, CHWs, and my fellow adolescents on care at EDAP for the support they have given me to the person I have grown to be. EDAP has become my home far away from Busia, Kenya. We need to advocate much of people who are living HIV positive, like let's say me and adolescents on the facilities, to be part of the education, health education to among the youths. Let's say like a leader like me who is public on my status and I do talk about HIV, we can get more of youth at the facility level or outside the community whom we can support on peer-to-peer, whereby it can be of a very much benefit. And also, I would just wish we continue empowering more youths who are living HIV positive so that they can give hope to the society. But for now, most of the stigma that is killing people is self-stigma. Most of the people have not accepted themselves. That's why at IDAP, the social workers, the counselors, the doctors are doing a very good job, at least to help people who test HIV positive, we young people who are living HIV positive, at least to accept ourselves and have hope that there is life. And I would encourage most of the NGOs or any organization, when they come on board, let them involve the youth in implementing their purpose in this country or the community they will be touching. Because let's say like IDAP for now, they involve us as youth, we are peer mentors. So at least it's much easier for most of the youths to open up. As I finish, I would like to say there is hope. Thank you so much for listening to me and may God bless you all abundantly. Asanteni sana, karibu IDAP.
My name is Brian Kipchumba. I'm grateful for this opportunity. I am 27 years old. I am living with HIV. I was born with HIV, so basically I have lived with it my entire life. I was growing up in that space, growing up in that area whereby you have to deal with a long life illness. I got the opportunity to meet with other young people or other children like me. I started as we continued, of course, with care and everything. Yeah, I've had experiences where I've had to lead. I've had to lead support groups. I've had to organize for more youth-friendly or adolescent-friendly centers. These are centers that will focus on the needs or on the requirements of adolescents and young people living with HIV. They do help them because one, getting enables them to get the psychosocial kind of support. Yeah? It also helps them, realize the kind of talents they have and giftings, and by just creating a space whereby they can meet and exchange ideas. There are a few. Okay, here we call them chamas, but these are groups that are for economic empowerment, basically. It has enabled them to grow financially. One thing I understand, especially with young people and adolescents, especially where I come from, is that they tend to shy away, especially whenever they see an older person. So they may not be able to talk. They may not be able to really say whatever they're going through. But, just leading them in a way where they're within their peers has enabled us to find out issues that they've been going through and probably been keeping quiet about. I guide them through care because that's basic. Yeah, we achieve this through having support groups and focused group discussions. We also achieve them through one-on-one sessions, just listening to them and helping them find somebody who can be able to, or linking them to someone who is in a position to help them. Some of the challenges I get to see, especially when it comes to leading them, is number one, there are those that start engaging in other risky behaviors, yeah? Such as drugs, which is something that is a really big challenge. Another issue is, especially when we are talking about orphans and those who are vulnerable, because probably they don't have a stable place, they don't have a stable home, they may end up being victims of abuse. Another challenge comes in terms of keeping them in school because they may not be able to pay their fees as expected, not unless the government or any other NGO walks them through. They are not completing the education. My number one recommendation that they should look on how to walk them through school so that they can just complete their education without having to worry about the school fee and everything. Another recommendation would be giving them a place, and I'm talking on behalf of orphans and vulnerable children, just getting a place where they can, let's say, call home until they are mature enough to handle themselves. Another recommendation is to see them partner and see on how we can really work on the risky behaviors. That's drugs, that's engaging in sexual activity that puts them at a risk. I think it would be a recommendation if probably they'd find partners here and to see what can be done in those areas. I think what young leaders really need is guidance, or should I say mentorship, from people who have been there before, from people people just who are willing to provide this kind of mentorship. Because honestly, at times, reaches a point you feel like it's also heavy on your side, and you just or those moments you really don't know what to figure out. Yeah. So I'm thinking if young leaders can have that kind of mentorship, it would be a good thing. And also if they could be a way to have a platform where these young leaders can meet, share at that level, like what they're going through, what has worked on that other side, it would be a really nice thing so that you can keep growing and keep helping. Okay, thank you.
Well, thank you so much. We've had some very powerful stories from Franklin and from Brian, and it's really we shouldn't take these stories for granted. The power to experience these events, but also the willingness to share is something that it is really powerful, and we should never take for granted. So thank you so much to both of you. Moving on, can I just invite Vanessa? Vanessa, if you can hear us, just going on from what Franklin and Brian has just shared, could you just elaborate a bit as well on your experience?
Good day, everyone. I'm Vanessa Fernandez, a youth person living with HIV. Greetings to you from the land of sea, sand, and sun, and the smallest state of India, Goa. I am with Human Touch Foundation, a youth-focused NGO as a peer body. The foundation works with young people across the state in the areas of TB, HIV, sexual reproductive health, substance abuse, and cyber safety. Born and brought up in Maharashtra, a different state in India, I sought admission in aftercare facilities of Human Touch Foundation to improve the qualities of my life, which was getting worse due to many reasons. I have lost my mother at very young age. I admitted a child care institution run by young faith-based organization. As my dad found it difficult to look after me, I grew up in a spiritual-led atmosphere where the staff provided their continuous support. However, my knowledge regarding my health issues was very limited. Since the disclosure of my status was not done properly, I began to take the medication because I was asked to, not knowing what it had to do with my body and virus. As I grew up, I began gaining awareness about HIV and found it difficult to accept my status. But I still continue to take my medication at the age of 18. Due to regulation of childcare institution, I was asked to move out. On returning home, I was forced to discontinue my studies and care for my dad, who was ill. I worked to meet our financial needs. Everything was fine until the pandemic hit and I lost my job. Unemployment, financial difficulty meant that we did not have access to nutritious food and my health began to get worse. It was very stressful situation. Also, the lockdown did not permit me to collect my medication because the hospital was far away. I did not have the money to travel. I became very anxious. I was not able to take my medication almost for 6 months and my viral load had increased. To help me gain my health back, my aunt referred me to Human Touch. At Human Touch Foundation, I received lots of support, and the team addressed my psychological and social needs. Undergoing therapeutic session helped me understand HIV as illness, not a burden. They made me aware of the importance of adherence to the treatment regime and suppress the virus in my body to protect myself from opportunistic infection and keep me healthy. The counseling session also helped me cope with the stress surrounding the illness. I found it easier to acknowledge my status and learn to prevent my future positively. I was I was surrounded by people who saw potential in me, exist in me, exist in me continue my future education in order to have stable career. Being far away from home, I helped me to realize that along with external support, I need to take responsibility to external in my overall well-being. Having received so much, I have received so much of assistance and experiencing growth in myself. I want to make a difference in the life of other adolescents and young people living with HIV. As a peer buddy, engaging and delivering peer support has helped other young people living with HIV to openly discuss their issues, building trust to share similar shared experience. Observing the needs, educate my peers about HIV, the treatment, viral suppression, nutritious diet, and mental health, and so on. I started having conversation to help them relate to me. Young people living with HIV engage in social activities in secrecy, as they do not want to discuss their status with hands, and they are not able to access social support to cope with the difficulty situation, and they are left to find fend for themselves. Through peer support, I wish to be a role model for others cope and manage HIV. Accepting one's status assists in improving treatment adherence. As I have experienced in my life today, I have reached undetectable level and I want to help others to get there too. I want to guide young people living with HIV to make the right decision to improve their overall qualities of their life. Having shared my life experience, I must say that faith-based organization has done marvelous work with children and adolescents living with HIV in India, especially in the areas of care, support, and treatment. But in recent time, as the HIV care changing with the effectiveness of ART, I see dangerous complexity creeping in care, support, and treatment, especially in the emerging needs, that is, access to viral load treatment and monitoring, sexual and reproductive health, stigma and discrimination, access to livelihood, housing, thus affecting the health outcome of large numbers of adolescents. Living with HIV, we are invisible in national programs as well as in plans by civil society organizations, including faith-based organizations. I urge faith-based organizations to consider our emerging issues in their programs. We also have similar dreams, hopes, as well as adolescents. Well, I'm lucky to found support. Most of my friends are still struggling to gain the sense of autonomy and establish their individual identity. A small note a small note to my fellow young people. As a young people living with HIV, you will face numbers of challenges. Be open to seek help and guidance. Stay strong, believe in yourself, pat yourself on back after small achievement. Keep motivated and you will achieve a greatness. Thank you.
Tipita moyo moyo onse okosa uyu amai musadenda ule na vuto yose tipita mo aya yazapita iwe yazapita ma.
Thank you so much, Vanessa. Again, What inspiring stories. I am in awe, I have to say, and I'm not just the only one. I'm seeing the chat box here. It's been flooded with messages of support, but also I think people understand as well that it's never it's one thing to go through the experience, but then it's something else to have the courage and the wherewithal and the knowledge to share as well. So we would like to thank you so much. And you raised, really, really great. You opened up, a box for us here, on adolescent-friendly health services, on disclosure and how to disclose to young people, the power of that. Of course, on stigma and discrimination, which annoyingly so, we still face. It's still very rife in communities, but also in engagement and in the meaningful participation and involvement of young people. So absolutely fantastic. Thank you so much. And again, I'll just use this to move us into the next session. So we've looked at challenges, challenges with adolescent leadership. Maybe they're good stories, that we can, probably see from countries to say what practices have helped. How have we been able to use these experiences that, Franklin and Brian and Vanessa have shared so explicitly and fantastically? How can we use that to leverage action? What lessons do we have that can guide us into the future and that we can, point at and sort of scale up? For that, we have, quite an impressive cast here to help us talk through that. Again, as you've done for the first session, with your great comments and suggestions and recommendations, we would implore you, to get engaged in this one as well. This is about, lessons learned from programs and, examples in the faith-based organizations. So first we would have Gladys Mukaratirwa, who is a program coordinator at Chedza Community-Based Orphan Welfare. She's going to talk to us about the pediatric and adolescent adherence to ART support groups. We heard a lot about peer-based groups from Franklin and others. She's from Zimbabwe, and she would be talking to us in a moment. After that, we would have another video from Anthony Mtali Ngwira, who is the country programs coordinator with the New Apostolic Church Relief Organization, NACRO. And we will talk to us about family interventions for adolescent HIV prevention in Malawi. We had a few questions on prevention, so great to hear from Anthony on that. And then finally, we will move to Tiffany Riggleman and Colin Moody from the Luke Commission, who will talk to us as well about the very popular teen clubs in Eswatini. So excited to hear from these three, and again, keep the chat box alive. Let's engage and discuss these really critical.
We are director for Chedza Community Welfare Trust, a community-based faith organization which operates in Mutasa District, Manicaland, Zimbabwe. Our main focus is on integrated HIV, SRHR, maternal health, child protection, and women and girls' health. We focus mainly on children and adolescents who are affected or infected by HIV. My presentation is on pediatric and adolescent adherence to ART support groups, Zimbabwe. Focus of intervention: identifying and testing missing children and adults, access to HIV treatment, retention and adherence, and viral load suppression. Faith community asset area, faith-inspired health service providers, advocacy by religious leaders, community health outreach. Description of the intervention. The main aim of the intervention is the formation of support groups at Bonda Mission Hospital and other rural health centers to encourage art adherence by children and adolescents. The support groups are made up of between 3 to 6 members, comprising parents, caregivers of children living with HIV, as well as children and adolescents living with HIV. The main faith leaders are involved in several ways, helping to remove stigma associated with HIV in their congregations, encouraging their members to take and adhere to their art medication, seek medical attention when required, and to participate in the support groups. Key elements of the intervention. Children and adolescents on art are identified from the health facility and in the school health program. The school health master is involved to ensure the children are taking their medication. He or she keeps a register of the children on art. The defaulter tracker trained in art adherence coordinates the school and health facility. She organizes monthly meetings and collection of art for adolescents and children who live far away from a health facility. Parents, guardians of these children also form their support groups. When they bring their children to the monthly meetings, they also meet and support each other on adherence. The default tracker follows up on children who have not turned up for their medication with the medication. The support groups are provided with support and capacity building. Lead organization. Chetha Community Welfare Trust is a community faith-based organization working with Bonda Mission Hospital, other faith-based health facilities, and government clinics in Mutasa District, Manicaland, Zimbabwe. The intervention was carried out at 3 faith-based health facilities and 14 government rural health centers in hard-to-reach communities. Results of the intervention are outlined as follows. Support groups comprising 3 to 6 members were set at all 17 health facilities which had HIV-positive children and adolescents. They were established and supported with the involvement of local authorities, traditional religious leaders, parents, and the community at large. The number of children and adolescents having an HIV tested increased from 606 in 2015 to 1122 in 2020. There were 69 children and adolescents who adhered to their art medication in hard-to-reach communities. Impact of intervention. More adolescents and children were tested for HIV. Children and adolescents adhered to art. Stigma in children and adolescents was reduced. Key success factors helping the implementation and scale-up of the intervention. Working with faith and traditional leadership. Working with local health service centers, having a defaulter tracker to follow up on art defaulters. Key hindering factors constraining the implementation and scale-up of the intervention. White garment religious sects who do not believe in modern medicine. Limited resources to cover more communities. Thank you.
Thanks so much for giving me this opportunity to share with you the lessons learned in our project we implemented in Pamba, Nkata Bay, titled Family Interventions for Adolescents HIV Prevention. I am Anthony Ngwira, the Country Programs Coordinator for the New Apostolic Church Relief Organization. NAPRO is an NGO under the New Apostolic Church in Zambia, Malawi, and Zimbabwe. And this NGO was formed in the year 2002. Now, coming to the project itself, the overview. Committee members still have mixed feelings on the prevention measures of HIV. Majority of committee members are still inclined to cultural and biblical beliefs that deter adolescents from accessing HIV services and that influence stigma and discrimination. Adolescents are so vulnerable to HIV infection as they are in the learning phase. Parents do not usually talk to their children openly about love, sex, sexuality, and contraception because they fear to encourage them to be sexually active or due to lack of adequate information. Adolescents therefore rely on their peers on information for sexual matters, and very often this information is inaccurate, confusing, misleading, and sometimes completely false. Hence, this project, with the goal of contributing to improved sexual and reproductive health and rights information among the young people aged 20 to 24, the project mainly used 3 approaches to increase awareness of an access to sexual and reproductive health and rights services by adolescents and young people in the family and target areas. The first approach was family intervention program. To reach adolescents and youth in and out of school, the project worked through family settings to provide and promote integrated sexual and reproductive health education and counseling services. The family intervention focused on supporting families to have positive perceptions and effective communication about sex and reproductive education to enhance HIV prevention. And building capacity amongst parents was emphasized to provide friendly and informative messages to the adolescents and the young people. The second approach that was used was school-based health program. And through this, NAPRO worked with the selected primary and community secondary schools with guidance and materials of the Ministries of Education and Health to protect and promote the rights of adolescents and young people to sexual and reproductive health information and services. The project promoted and provided health environment and an efficient means to improve the well-being of school-going boys and girls. And specific activities that were used included training of guidance and counseling teachers, guidance counseling sessions, identification of girls that need support, for example, sanitary materials and school fees, and then referrals to NAPRO for other support. The third approach that was used was church-based, integrated health education and services. NAPRO used the church settings to provide integrated sexual and reproductive health education and counseling services. The project worked with church-based women and youth groups to create awareness and increase demand for the adolescents and youths for integrated reproductive health education and services. This promoted voluntary abstinence, counseling, and other services to sexually active youths, gender-based violence, and preventions of sexually transmitted infections. Now, coming to the results of the intervention. We experienced some positive results, and these were improved family interactions for HIV prevention. Another result was that 82% of the women and girls that we target were engaged in income-generating activities and farming activities in order to get more money for their livelihoods. And this was done mainly by us creating savings and loan groups that were developed solely as part of the intervention. This reduced the women or girls' dependence, especially girls that were out of school, on their male counterparts. The other result was the social groups, church groups, and savings groups. These increased the number of meetings and mainstreamed issues of HIV and gender-based violence in their meetings. There was also an increase of church members engaged in HIV activities. 7% of the targeted parents were motivated to challenge the taboos and to promote adolescent well-being. According to Ministry of Health data, the number of new HIV infections amongst the children and adolescents in the targeted community dropped by around 29%. As well as the uptake of HIV prevention advice by the adolescents and young women was demonstrated in national health reports, which recorded a reduction in HIV prevalence to about 7.3% in 2016 in the Malawi North. The increase in knowledge of HIV prevention had positively contributed to the demand of HIV testing and treatment. Whilst there is evidence that the project strategies have been successful in engaging families and young people about HIV and reproductive health, more work remains to be done with some committee members and religious leaders to tackle belief in faith healing rather than ART treatment. However, there were some factors that promoted further implementation or possible scaling up of the intervention. And these factors included availability of evidence-based information on HIV and reproductive health from government and other institutions that do play a role in HIV prevention. Secondly, ability of NAPRO to integrate HIV prevention with other projects in education and livelihoods. In addition, families acquired knowledge and willing to discuss issues pertaining to sexuality with their children and able to work with faith-based organization on HIV prevention. We are well-positioned as an organization to reach out as there is clear understanding and good relationship with the local communities. However, there are still factors that hinder or that may hinder further implementation or scaling up of the intervention. These mainly were factors such as limited financial resources that limited the possibility of scaling up and failure to attract adequate expertise within the organization due to small budget. And at this point in time, I thank you for your attention. God bless you. Thanks so much.
Hello, my name is Tiffany Riggleman, and I'm going to be presenting about the Teen Club intervention in Eswatini utilized by the Luke Commission. So the Luke Commission is a faith-based NGO that provides free, comprehensive, compassionate healthcare to underserved clients in Eswatini. And we do this through a combination of services that are provided at the fixed site Miracle Campus, which includes a full inpatient, outpatient hospital, as well as a hub of operations that supports many up to 10 mobile outreach teams a day that are going all throughout the country. Last year, we saw over 117,000 patients. We're primarily motivated by faith, and we seek to treat every patient as their father, mother, brother, sister, or child. So when it comes to adolescent HIV, there's some unique challenges that adolescents face, and as they're dealing with these chronic illnesses. As a result, they often have lower viral suppression than the rest of the adult population. And so one of the solutions that we found as an organization was to implement what's called Teen Clubs, and that was launched in August of 2018. The main focus of Teen Clubs is to increase treatment understanding for adolescents and help them with their adherence to the chronic medication, the retention and care, and then viral load suppression ultimately for this population. The Teen Clubs offer a supportive environment to HIV positive youth ages 8 to 24. We have these half-day events held on Saturdays at our campus. We segregate them into similar age bands. So our first group is 8 to 14-year-olds, and we do that on the first Saturday of every month. Then we have the 15 to 19-year-olds who come on the third Saturday of every month. And then more recently, we started more of a young adult group, which meets on the fourth Saturday of every month, and that's for 20 to 24-year-olds. And they really focus on kind of transitioning into adulthood and some of the different challenges that young adults face as well. So the goal of Teen Clubs is to provide a safe and welcoming space for children and young adults as they gain treatment knowledge and also grow in life skills. The foundation of Teen Clubs is a nationally developed curriculum, but it includes a lot of other activities as well. And we just want to really help them and support them in their adherence to treatment. Also by creating and providing a stigma-free environment for receiving their ARV refills. The activities that we include at the teen clubs include things like group songs and activities, games, different life skills training. Participants will also take time to do written personal reflections at times, which are reviewed by counselors and help the counselors know how to support them better. We batch these with art refills. So as the clients come to the campus to get their art refills, they attend teen clubs at the same time, because we do have clients coming from all over the country. And then there's also opportunities for the participants to meet with counselors as needed or if desired, or sometimes parents will call us and ask us if we can meet with their child about a certain challenge they may be facing as well. So this includes, of course, stepped-up adherence counseling for their medication, but it can also be things just of any other life challenges that they need someone to talk to or need counseling about. So one of the tangible ways that we've seen teen clubs benefit the adolescents and also the program of pediatric ART is by increasing viral suppression rates. The top line is viral suppression rates around the time that we started the teen club. So it's kind of the baseline. And you can see that there's been an increase in almost every category over the last few years. And as well as overall significant growth in the number of adolescents that we're seeing through the program, from about 165 to now 373 adolescents. So some of the success factors are, really in integrating that comprehensive healthcare platform across all ages, which prioritizes trust building between TLC and the patients. And in turn, patients will often refer their friends and family to the Luke Mission. And when it comes to enrolling in teen clubs, that's something that we really tried to encourage in all adolescents from the moment that they initiate on art with us. And we try to just get them right away on the schedule for their appropriate weekend to attend the teen clubs and get their refills. We have caring and committed staff who are very skilled at providing the teen clubs and engage energetically and enthusiastically with the teens there. And then we also do transport sponsorship for eligible participants. One of the things that we do as an organization is provide transport reimbursement for all clients that are coming for their ART refills. And we see clients from all over the country, some that might have challenges with transport and getting even to their local facility, or they have a reason that they don't. Maybe their local facility doesn't provide intensive enough services for what they require, or they don't have maybe specifically pediatric friendly things such as teen clubs. So we don't want transport money to be a barrier for those clients attending class. So because we combine the teen clubs with the art refills, and then we give them transport money reimbursement when they arrive. So initially, when we started the teen clubs, they were aimed at a narrow age band, 8 to 13-year-olds, and then 14 to 19-year-olds. But the program has since been expanded to include additional age groups. As I mentioned, the 20 to 24-year-old group was added after noticing that there was a viral load suppression and retention gap with that age group. And then also most recently, we've noticed even viral load suppression and retention gaps with children and babies even. So starting even caregiver support groups that will help young mothers with young children as well be able to increase their treatment knowledge and their success on treatment. And thank you very much.
Super. Thank you so much. Again, just brilliant interventions all around. I just note as well that we are, running close to the end of the session. But can I just, say thank you to all of you, because I can see the chat box. It is so lively. I'm seeing so many, suggestions, recommendations. There are a few questions that have been posted on the Q&A box, which our panelists have done really fantastic to answer. There are just a couple which I will pose to them live. But before that, let me just acknowledge two things from not the Q&A box now, but from the chat box. The first was on the question about mental health. And I just wanted to say that that is, it's a really important issue, mental health for young people. There is data that shows that up to 50% of mental health disorders would have started by the age of 14 and up to 75% by the age of 24. So we can see in terms of burden for young people and mental health, this is quite a lot, and we need to, give cognizance to this. WHO in 2021, just this year, earlier this year, released the consolidated HIV guidelines, where one of the recommendations was on providing psychosocial interventions to adolescents and young people, to improve adherence, to improve viral suppression, and so on. So I'm just really acknowledging that comment to say that it's really, really important. Secondly, it's on HIV testing and self-testing. There's a lot of work that is being done by the HIV testing team at WHO as well, which we are happy to link you with and to help move that really important conversation along. So thank you so much. For the sake of time, I'm just going to have two questions posed to, first of all, to Chewe. Again, Chewe, really, really great presentation you made. And there's a question here, Chewe, on, engaging religious leaders and faith leaders themselves. Like we know, there is quite a lot, and in your presentation, it shows, the cascade of interventions from prevention to treatment to virus suppression. And the question was about refocusing on HIV prevention. What does this entail? And, its neglect. Why was it neglected in such a way that it has been overshadowed by other approaches, which, can cause religious leaders to sort of take a back seat for quite a while. So I just wanted to get your reflection and thoughts on that, Chewe, if you can.
No, thank you, Wally. I do think some of the accountability is on us to make sure we are working with faith leaders, because they are such an important interface with community. And I think whereas in the past we were very sort of generalistic in our approach in trying to get testing everywhere, trying to get interventions everywhere, we've known over time that we need to do a better job at prioritizing which geographies, which populations, what are we talking about in terms of risk profiling. I think the data that I presented point to the important work we have to do with adolescent girls and young women, but it also points to equally the important work we have to do with adolescent young boys, young men and young men. So I think part of the conversation is just creating awareness as to what our data is telling us, which communities we are concerned about, what type of populations are we concerned about. And I think the important role of the faith communities is to create that space for where adolescents feel comfortable to discuss their own fears and concerns, including their own sexuality. I think that's one thing that I would actually say. And then I think when it comes to targeted interventions, some of these interventions are difficult for our faith communities to take up. But I do think there's an opportunity and an accountability for us to start to engage faith communities in a very structured way in terms of how we can use their platforms to engage on some of these issues in a way that is meaningful to the populations that we're trying to target. And I think faith communities know how to do this. They can create those spaces, but I do think we need to sort of be in the same space with them around what is it that we know will have impact moving forward. We have structural interventions, we have behavioral interventions, we have biomedical interventions like PrEP. people have talked about self-testing. I do know that in the prevention of mother-to-child transmission, for example, we did some very good work with support from PEPFAR, looking at how we can promote HIV testing amongst couples that, to prevent mother-to-child transmission with very good results. So I do know that this is a platform that we haven't leveraged enough. And I think the work is for us to really recognize this and make sure we take our tools into the spaces where faith communities interact so that we can have a win-win sort of situation. Over.
Fantastic and impressive. Thank you so much, Chewe. I couldn't agree with you more. And I'll just move, onto Laurel for the next probably final question. Again, any question that is in the chat box that. So we've answered all of the questions in the Q&A, but for the chat box, if there are still any comments or suggestions that have not been responded to, we will be putting this onto the platform, the website, where we would have a sort of Q&A response there. So, Shannon and Anjali, said, and I was quite struck when they talked about, raising the expectation, being bold, as we move forward. And I think that's really spot on. And I wanted to know how we can, apply this, because it's a mentality as well. I wanted to see how we can apply this to the meaningful engagement of adolescents and young people. And I wanted to go to Laurel. What would meaningful involvement of adolescents and young people look like within faith communities in the light of the GIPA, greater involvement of people living with HIV principles, which we are all familiar with? Laurel, please.
Sure, Wally, thank you so much. And Jane, thanks for the really good question. I'm sure we could have some long conversations because I think you have also some very powerful ideas on this that would be helpful for the conversation. But in the interest of time, just really quickly, I think when we're talking about the meaningful engagement of adolescents and young people living with HIV and the JIPA principle in faith settings, of course, it's very similar to non-faith settings. And as we see around the world in all settings, we're way too slow to actually let young people lead and to support their leadership. I think the leadership by young people is often the last that we think of. We're way too often ready to speak for young people instead of supporting them to speak on their own behalf. And really, this was a delightful session to actually hear young people say to us what their experience is, what they need, and how they are leading. Just really quickly, when we're talking about the meaningful engagement of young people, we do need to think about young people in all their diversity. And really, I want to support the comments that Chewe just made that were so important about how that can be challenging for faith communities. But of course, also for faith communities, young people need that kind of love and support across all of the diversity of young people in key populations, young people living with HIV. And meaningful engagement of young people means that they have to be included in planning of activities, of implementation of those activities. And sometimes there needs to be a budget for young people to be able to lead that is managed by them. They may need support, but support can often be provided by older adolescents, and Y+, the global network of young people living with HIV, is just one example of a network that could provide support for young people as they're organizing. Few key points is that when young people are being engaged and engaged to lead, that engagement has to be non-tokenistic, it has to be diverse, and it has to be multiple. And by that, I mean bringing in one person that's been handpicked as a young person to tell grownups what they need to do is not actually empowering for young people. Bringing together multiple young people who have diverse backgrounds and experiences, supporting them to come together and understand from one another and share with one another what they need, helps them all to come forward with more power and legitimacy, not to be so easily overruled by some of the power dynamics that sometimes force them to be quiet while adults speak. So it gives them a source of power together, and also builds their capacity to more broadly understand what young people other than themselves need, so they can speak together in a stronger voice. we have to really pay attention to safety, of course, and remember that as with any group, just because a space is an adolescent space doesn't mean it's safe for all adolescents. And faith communities can really play a role in making sure that the work is being done, not just with adolescents, but more broadly, to think about and respond to internalized as well as external stigma and discrimination related to HIV, but also related to LGBT people, to young people who are using drugs, and others in their diversity of experiences. So really what we need to do is shift from doing things for young people and adolescents to doing things with young people and adolescents, and finally to following the leadership of young people and adolescents so that they are able to play their proper role in supporting themselves and each other in the HIV response. And I think this question about needing a package for faith leaders and communities is an excellent question. And I'd be really interested to see what we could do to support young people to work to develop such a package on the JIPA principle and the meaningful involvement of adolescents and young people within faith communities. So thank you so much.
Thank you so much, Laurel. I think, super comment. And I really do agree with all of what you've said as it relates to engaging young people as well in their diversity. We had comments about young people not being a homogeneous group as well. I think this is super. So I would like to just say, thank you to everyone. We've had a fantastic session. I had huge expectations for this session, but this is even beyond my dreams. So I want to thank everyone, all of the people that have been on the panel for their insightful comments and also for sharing their lived experiences. Just before I hand over to to those who would give us the the closing remarks, I just wanted to leave you with this, to say that 40 years since the first cases of what we now know as AIDS, came to us, it's been, a message of hope as well. Giant strides have been made, but like we've seen from, the presentations, there is still so much that we need to do. We are now at what we can call a critical juncture. It's 10 years to 2030, the end of the Sustainable Development Goals. So the question is, how can we move quicker? How can we move with more purpose and leverage the strengths that come to us naturally? There is nothing that comes to us as naturally as faith. So I would like us to just have that in mind as we move forward and as we refocus our attention, our work, and our resources to the people and the communities in which they live. So on that note, I'm just going to hand over first to Sandy Thurman, who is the Chief Strategy Officer in the Office of the U.S. Global AIDS Coordinator and Health Diplomacy, the U.S. Department of State, who will then be followed immediately by Suki Beavers, who is Director, Gender Equality, Human Rights, and Community Engagement with UNAIDS, to give their closing remarks as I hand over to Sandy to start.
Unmute. There we go. Thanks so much, everyone. And I know we're running a little behind, so I think I want to try to hit just a few high points. But thank everyone for the incredible presentations that we've heard today. I agree that this meeting has certainly exceeded my expectations, and I think those of others as well. First of all, I just want to remind us hearing this today that when we're working with our faith-based partners, there is such an incredible framework to be leveraged, because these organizations are rooted in communities, and they are with families and the people in their communities from their cradle to the grave. So they are built in to be able to help us move through the transitions of people, young people in particular, into adolescence and into adulthood. So this is a great built-in structure for us. First of all, just to remind us that, youth have always been, young people and adolescents, always an important part of our response to HIV. And this just sort of rekindles that, this conversation rekindles that for us. And so I want to thank Francesca and the team at UNAIDS for giving us this opportunity. Again, we need tailored approaches, which we discussed at length. We need new leadership from youth, and that's an ongoing process. We don't just, we can't target youth and then think we quit, because young people are coming of age all the time, and we can't forget that. We want to continue our focus on peer-led and peer-supported programming. I think that is incredibly important. We know that. It's not like we don't know it, but we just need to re-emphasize the fact that we need to do that. Anjali talked about something that I think we also can't ignore, and that's the youth bulge that we see in the places where we do most of our work in East Africa and Southern Africa and other places as well. We have this unbelievable tidal wave of young people coming of age, and we need to make sure that we are riding that wave like we need to, and reaching these young people with key messages and training them to be leaders. We need, and I think this was pointed out, it's true in Dreams, it was true with all of the presenters today, that we certainly need to have more comprehensive approaches. That of all the things that we do, comprehensive approaches are the most critical, and we can't forget that. The one-off ones just simply don't work. I wanted to really thank Brian and Franklin and Vanessa for their interventions. I mean, these are the voices that we need to hear as we plan our programs and execute our programs. These young people are our best partners and our best advisors and how to reach other young people, and we don't want to forget that. We talked about the need to find stable environments for young people, particularly orphans and vulnerable children. We talked about the need to train new champions, and I think this is a good time for us to focus on that. We talked about the fact that these faith-based institutions that are in all of our communities are not just communities of faith, but partners to our other private sector and public sector clinics and other organizations as well. And we need to make sure that we think about that moving forward, that these are, again, built-in structures that we can leverage, and that our faith-based organizations just don't do church or mosques. They're involved in schools, and they're involved in healthcare delivery in a very significant way in all the places that we work. And so just makes this an easier match for us if we choose to leverage that. I want to thank particularly our NGO partners who talked about both their successes and some of the challenges. We've made a great deal of progress in many ways, but we still have a lot of work to do, particularly around sex and sexual and reproductive health education, and stigma and discrimination. Everyone talked about that, and I think that was really important. One of the things that I thought that was also important that makes our faith-based partners a little different from some of the others is this sort of built-in comprehensive approach, built-in infrastructure to do group work, and caring and committed staff that are just part and parcel of what our faith partners bring to the table, and that can't be underestimated. And I just want to close by saying that in this conversation, which many of us in the meeting today have been having for decades now, it just reminds me that the more things change, the more they stay the same, that our investment in young people is our best investment, because if we build leaders when they're young, they will still be leaders when they're old, like some of us. So I want to stop there and again thank everyone for their participation today, and hand it over to Suki. Thank you.
Thank you so much, Sandy, and thank you, Wally. And I want to start by reiterating thanks to PEPFAR for the ongoing support for joint UNAIDS PEPFAR Faith Initiative, and for supporting this annual GA event that brings so many of us together. It's really hard to
think about how to close a session like today's, because there were just so many important contributions made from adolescents and faith leaders and faith-based organizations and community groups and PEPFAR and the UN system about what we know must be done to meet the targets set in the global AIDS strategy and the new political declaration, including that require a really focused and specific commitment to adolescents. The presentations and contributions today really reflect clearly that no greater actions are needed right now to control the HIV and AIDS epidemic than empowering adolescent girls and young women, engaging adolescents in all their diversity as key partners, as well as focusing on men and boys to be part of the solution. I really want to reiterate the call we heard today to move boldly forward with comprehensive packages that bring together social, economic, and biomedical interventions that both reduce girls' vulnerabilities to HIV and increase their agency. And at the same time, we really have to step up our efforts to build HIV testing and treatment programs that attract and retain the male sexual partners, including of young females. You know, both Shannon and Anjali and then Chue and Laurel emphasize that engaging adolescents in all their diversity and in all aspects of HIV programming not only improves young people's utilization of services, but also helps to ensure that the services actually respond to their needs and preferences. If we're serious about ending AIDS, and we are, it's time to create spaces to listen to and share with our adolescents, but also to facilitate adolescents speaking together, strategizing, and finding those spaces to lead. We really must continue leveraging the unique reach, compassion, and structures that communities of faith have to empower and support the autonomy and leadership of youth as critical to the HIV response. And you know, we heard so many great examples today of how working with faith and traditional leadership is a key success factor in helping the implementation and scale up of interventions. And you know, we heard today so many calls for and examples of how to build those bridges for the adolescents that are most left behind. And I want to name them, you know, lesbian, gay, bisexual, and transgender adolescents, adolescents who use drugs, those that are migrants, homeless, and those in closed settings. And again, you know, Laurel spoke in responding to the chat question about how important increasing investments in and giving money to and control over those resources to youth-led responses and young people's leadership is really an important first step to achieving the targets related to young people. It was really telling today that all the interventions, you know, the lessons learned that were presented today mentioned support groups and peer-to-peer groups in faith settings as great tools for increased case identification of children and adolescents and treatment adherence and reducing stigma levels. And we heard really clearly through these support groups that a large variety of services are provided to adolescents, including positive living information, adolescent sexual reproductive health and rights information and services, educational support, nutritional support, peer-to-peer counseling, capacity building and income generating activities for parents and caregivers of children and adolescents living with HIV, the teen clubs and support services. You know, we heard great examples of how they specifically focus on helping transition adolescents and young people and addressing their unique needs. It was really, really interesting to hear about the Family Intervention for Adolescent HIV Prevention Project, which has contributed to improving sexual and reproductive health and rights information among young people aged 10 to 24 in Malawi. And all those important interventions that support families to have positive perceptions and effective communication around sex and reproductive education to enhance HIV prevention as so important. And I want to end by reflecting on the fact that all of the adolescents who spoke today were so clear that not only do they want to, but you are already making a difference in the lives of your peers living with HIV. But we also heard clearly that challenges and pressures are growing due to COVID. Stigma and discrimination are a big limitation to accessing HIV services. The issue of disclosure really must be addressed. All the young people that shared today talked about how they were not told the truth initially about their HIV status. I also heard really clearly that adolescents want to be our partners, and we need to learn to be better partners to adolescents. It's really, you know, I leave today, and I hope all of you do too, with even greater clarity about the unique and critical role of faith communities in supporting adolescents' prevention, treatment, care, and leadership in the HIV response. So really, thank you to all the panelists and the participants for all the concrete suggestions and also the inspiration provided today. Thank you so much to all of you. Back to you, Wally.
Thank you very much. Can I ask Father Rick to proceed, please?
Okay, and next slide. And so we gather together again as people of faith. We call to mind the presence of the Creator, the presence of God as you understand that word. God of hope, source of light, healing, and compassion, all of us are affected by HIV and AIDS. We thank you for this time to gather together during the UN General Assembly. We thank you for our speakers, especially the voices of our young people, our health workers, and our faith and secular leaders. We pray for wisdom and justice as we address the needs of HIV-positive adolescents and young people and prevention for all young people. We pray to hear and listen to the voices of young people affected by HIV, for continued advances in medical, emotional, social, and spiritual supports for adolescents and young people living with HIV, for greater awareness, concern, compassion, and advocacy in our faith communities, and for an end of all forms of stigma and discrimination. Source of all unity, bind us together with love so that all places of worship may be places where all can experience acceptance and belonging. May they be places where care is given and received, especially for affected children and adolescents. May our places of worship be places where stories are told and heard, where fear is overcome by love, where hope and compassion are always found. God of promise, the end of AIDS is in sight. Give us the courage and the wisdom to continue our passion, compassion, generosity, and justice, so that all who need access to welcoming education, clinical care, and support can receive affordable, quality, and comprehensive treatment. Amen. So be it. May it be done.
Thank you so much, Father Rick. And, you know, that's just the right way to end. Thank you so much. And I'd like to thank, alongside everyone who's been here, I'd like to thank as well the interpreters and everyone who's provided technical support. Without them, of course, we couldn't have done this. So congratulations to everyone, and thank you so much as I close. Bye.
Thanks, everyone.
Yazapita,